Navigating the complexities of cardiovascular disease prevention requires a sophisticated understanding of risk factors and evolving treatment strategies. Recent insights offered updated perspectives on assessing atherosclerotic cardiovascular disease, or ASCVD, risk, and managing lipids, emphasizing personalized approaches and next-generation insights into patient care. A significant stride in personalized risk assessment comes with the introduction of the PREVENT calculator. Designed as a potential successor to the pooled cohort equation, or PCE, it aims to provide a more equitable and comprehensive evaluation of ASCVD risk. This tool applies to adults between the ages of 30 and 79 who do not have known cardiovascular disease. Notably, it replaces race with a social deprivation index, utilizing zip codes to account for crucial social determinants of health. The PREVENT calculator also incorporates eGFR and can optionally include albuminuria via urine albumin-creatinine ratio and hemoglobin A1C to further personalize risk assessment for diabetes. It calculates a 10 and 30-year risk for total cardiovascular disease, ASCVD, and heart failure, moving beyond just heart attack and stroke. This risk score establishes a baseline, allowing risk enhancers to guide treatment decisions when a patient's risk is borderline. When considering atherogenic burden, particularly in cases of elevated triglycerides or insulin resistance, non-HDL cholesterol often serves as a superior marker. This measurement encompasses total cholesterol lightest HDL cholesterol, reflecting the complete concentration of all atherogenic ApoB-containing particles. It offers a more precise gauge of atherogenic burden compared to LDL-C alone, especially when triglycerides are high, often greater than 200 milligrams per deciliter, or in conditions like diabetes, obesity, or metabolic syndrome, where LDL-C can underestimate the true burden. Guidelines suggest that the non-HDL-C goal should typically be 30 milligrams per deciliter higher than the LDL-C goal. Beyond standard lipid panels, screening for lipoprotein A, or LPA, at least once in adults is now recommended, given its prevalence as a highly atherogenic risk factor. Affecting an estimated 1 in 5 people worldwide, LPA is almost entirely genetically determined, meaning a single measurement can suffice for a lifetime assessment. It's considered a triple threat, contributing to pro-atherogenic, pro-inflammatory, and pro-thrombotic mechanisms, likely due to its structural similarity to plasminogen. Clinicians must pay close attention to units and thresholds, as they can often cause confusion. Many labs report LPA in nanomoles per liter, with cut points generally considered low at less than 75, intermediate between 75 and 125, and high at greater than 125 nanomoles per liter. While there is currently no specific therapy to directly lower LPA, clinical trials are actively investigating new treatment modalities. An elevated LPA acts as a significant risk enhancer, which can justify earlier statin initiation or intensification and prompt consideration of a coronary artery calcium or CAC score in otherwise borderline patients. Conversely, apolipoprotein B or ApoB testing is not recommended for universal screening, but should be reserved for specific clinical scenarios. ApoB quantifies the number of atherogenic particles, and an ApoB level greater than 130 milligrams per deciliter is commonly recognized as a risk-enhancing factor. However, widespread implementation of ApoB testing is currently considered premature, potentially creating unnecessary hurdles in care. The concordance between non-HDL-C and ApoB is typically very high in most patients. Therefore, guidelines generally suggest ApoB testing in situations where discordance is more likely, most commonly in patients with significant hypertriglyceridemia or those with metabolic syndrome, diabetes, or obesity, where many particles may contain less cholesterol per particle. Another instance for consideration is in patients on therapy with very low LDL-C, for example less than 70 milligrams per deciliter, where ApoB might offer additional clarity. When a patient falls into an intermediate risk category or is ambivalent about statin therapy, a coronary artery calcium or CAC score stands out as the single best tool for risk reclassification. This test essentially measures calcified plaque burden. A CAC score of 0 indicates a very low 10-year risk of cardiovascular events, making it reasonable to defer statin therapy and consider reevaluating in 5 to 10 years. Conversely, a high CAC score, greater than 100, or above the 75th percentile for age, sex, and ethnicity, significantly escalates risk and strongly supports initiating statin therapy regardless of age. Scores ranging from 1 to 99 generally favor statin use, particularly in individuals over the age of 55. It is crucial to remember that a score of 0 does not rule out the presence of non-calcified soft plaque, nor does it provide a license to disregard healthy lifestyle habits. In cases where a patient presents with a baseline LDL greater than 190 milligrams per deciliter or responds poorly to high-intensity statins, familial hypercholesterolemia, or FH, should be considered. This genetic condition is surprisingly common, affecting approximately 1 in 250 people. A strong personal or family history of premature ASCVD can also be a significant indicator. A poor response to maximal statin therapy, defined as less than a 50% reduction in LDL-C on the maximally tolerated dose, suggests dysfunctional LDL receptors, which can blunt the medication's effect. Physical examination might reveal telltale signs, such as tendon xanthomas, especially in the Achilles or extensor tendons, and corneal arcus. Finally, statin should be presented to patients as a means of reducing overall risk, rather than simply treating a numerical value. Research indicates that each 39 milligrams per deciliter, or 1 millimole per liter, reduction in LDL-C can lead to about a 22% relative reduction in major vascular events. For patients who develop statin-associated muscle symptoms, or SAMs, a structured approach is key. The statin should first be paused to determine if symptoms resolve. If they do, the patient can then be rechallenged with a lower dose or a different statin. If SAMs recurs, patients might benefit from trialing long half-life statins, such as atorvastatin or rosuvastatin, with less than daily dosing, perhaps every other day or twice weekly.
This strategy can maintain significant LDL-lowering efficacy while improving tolerability. If LDL targets are still not met, non-statin therapies can be added to the regimen. In essence, these updated insights underscore a dynamic and patient-centric approach to cardiovascular prevention. From advanced risk calculators that account for social determinants of health, to a nuanced understanding of lipid markers like non-HDL cholesterol and Lp(a), and the strategic use of tools like the CAC score, modern medicine strives for more precise and equitable patient care. Furthermore, recognizing conditions like familial hypercholesterolemia and employing flexible strategies for statin management ensure that the journey toward reducing ASCVD risk is both effective and tailored to the individual.